So we move on to our next talk, and that will be by Dr. Sunil Sathe, and he is going to talk to us about optimization of medical therapy in heart failure. So Dr. Sunil Sathe is a well-known cardiologist from Pune, and he is currently associated with Giriraj Hospital and Intensive Care Unit in Indapur, Pune. He also has the Diplomate of National Board in Cardiology and has been listed as a noteworthy cardiologist by Marquis Who's Who, and is a consultant cardiologist at Pune Research Center since 1994 and chief electrophysiologist at the Ruby Hall Clinic in Pune also since 1994. So over to you, Dr. Sunil Sathe, for your talk.
Okay, dear friends, today I'm going to speak for the next 20-25 minutes on optimization of medical therapy in heart failure. Before we start with optimization, I would like to know success with failure is not only science, it's the science and art both. In fact, we have to look at a lot of things when we treat our patients, basically when we are medically managing patients with heart failure. Before going to optimization, you must know the concept of treatment. In a patient with heart failure, there are two aspects to the heart failure management. One is congestive phase, is congestive heart failure, and what is called chronic heart failure, where we are basically looking at mortality. Congestive phase, we know patients may be admitted, maybe on OPD basis, but we are treating their congestive symptoms. While chronic heart failure, we're looking at all the drugs which actually reduce mortality and hospitalization. Now, what do you mean by optimization? That means when I am saying optimization, when I am giving medical therapy to my patients with heart failure, what am I going to look at? Is there a checklist? And how do I go on optimizing patients depending upon which drugs I am giving? So basically, I look at the criteria of optimization and then drug management. That means which are the patients, which are the drugs which I would use to give the best optimization to my patients with congestive heart failure. Now, I look at congestive heart optimization. What is my aim? I've got three aims. One is I want to reduce symptoms or make the patients asymptomatic LV systolic dysfunction. I want to reduce hospitalization, and I want to reduce mortality. So these are the three main aims in my treatment of heart failure patients. Now, what do I mean by optimization? When I look at optimization in patients with heart failure, I want clinical optimization. I want optimization of rate and rhythm. I want metabolic optimization. I want enzymatic optimization, and I want, most important, is drug optimization. So when a patient comes to me in the clinic or in a CCU admitted with decongestive phase, I want to look at the following things. That is what I'll be sure that I have optimized my patient perfectly. So starting with clinical optimization. What do I mean by clinical optimization? And we all know the classical Foster's classification. These are the four subsets, simple clinical subsets. My patients ideally should be warm and dry. That is asymptomatic LV systolic dysfunction. Even if my patient is admitted in a cold and wet, that is the worst, because these are related to hemodynamics and treatment. So these are the simple clinical subsets of Forester's and Stevenson's classification. In the clinic or in the CCU, I want to make my patient warm and dry. When the patient is warm and wet, it's volume overload. When the patient is just cold and clammy but dry, it's low output but normal EVDB. And the same thing is correlated with drugs. So when the patient is warm and dry, it's ideal. That means I've optimized them medically. Okay. Then I look at mortality. When the body is warm and wet, yes, it's diuretics. It may be only inotropes when cold, clammy, hypotensive, but dry, and maybe inotropes for diuretics. So basically, clinical optimization is simple. My aim is my patient should be warm and dry. Second, rhythm optimization, rhythm management. Most important, sinus tachycardia, atrial fibrillation, and of course, ventriculectomy. I'll not go into details of ventriculectomy because it's a topic by itself. Two simple optimization of rate, and that is sinus tachycardia. Remember, sinus tachycardia is a marker of poor prognosis. And interestingly, it's a marker of response to therapy. There's a very good trial several decades ago, which showed that patients of heart failure with a basal rate of more than 90, when you gave them amiodarone and beta blockers, if the heart rate did not decrease below 90, see, the mortality is the same. So this is the significance of sinus tachycardia in heart failure, which we tend to neglect. Patient comes to us with a rate of 90, 100 or is discharged with a rate of 100 is not acceptable. So what do I mean by optimization? Of course, I would have beta blockers and evaporative. Now, what is optimized heart rate in heart failure? Optimized is at rest. My patient's heart rate should be less than 85, ideally between 65 and 75, as long as the patient does not have symptoms. That's number one. And the second important point, look for optimization in heart failure when the patient is on beta blockers, is what happens to the heart rate during mild to moderate exercise. It should be again optimal. That means it should not go beyond 140, nor should it not increase. So chronotropic competence should be perfect. Suppose you over beta blockade a patient, the heart rate may not move to more than 90 or 100 during exercise, and the patient may have fatigue. So optimization of heart rate is no sinus tachycardia and a good competent chronotropic competence during exercise, where evaporative should be only added if the patients do not tolerate beta blockers or beta blockers are not enough to control the sinus rate. Atrial fibrillation, I don't want atrial fibrillation because it hampers, it actually degenerates patients with diastolic heart failure when they develop atrial fibrillation. In moderate congestive heart failure, remember this, moderate congestive heart failure patients are the patients who actually worsen significantly with atrial fibrillation. So I want them to be in sinus rhythm. Severe end stage heart failure, honestly, it doesn't matter whether it's atrial fibrillation or not at that stage. And the fourth implication is CRT. When I am contemplating a pacemaker therapy for heart failure, I do not want the patient to be in atrial fibrillation because the response of these patients in atrial fibrillation is not good. So atrial fibrillation, second optimization in rate. Metabolic, I want electrolytes to be normal, especially potassium and sodium, both. No hyponatremia, no hyperkalemia, no hypokalemia. And of course, the third metabolic optimization is renal dysfunction. Now, hemoglobin is the second important. We have several trials. We must use more of carboxy maltose preparations to treat anemia in these patients. And of course, if they have significant CKD, then we use erythropoietin. Otherwise, use of carboxy maltose should be encouraged and increased depending upon the parameters to have this metabolic parameter corrected. Renal dysfunction, remember 4 things. Cardiorenal syndrome itself, cardiac LV dysfunction itself can cause hypoperfusion of the renal, and then you have renal dysfunction, number 1. Excessive diuretic use will increase your creatinine value, so be careful, do not over diurese. Comorbidities, of course, diabetic nephropathy associated will have a problem. And remember, all these 4 drugs, ACE, ARBs, ARNI, and SGLT2. Remember, drugs per se do not worsen renal function. The creat levels or eGFRs may reduce initially when you start therapy, but they will stabilize and eventually they will in fact improve. So remember this point, optimization of renal function, be careful, do not have a knee-jerk reaction of suddenly stopping ARNI or SGLT2 because your creat level goes off. If the creat, ideally you should look at eGFR, but if the creat level suddenly rises more than 25% of the baseline, you should reduce the dose or stop and reevaluate. So this is optimization of renal function. And yes, most important clinical optimization is improve hemodynamics. If you improve hemodynamics, which ARNI does, which SGLT2 drugs do, your renal function will improve, especially if it's cardiorenal. That means if it's LV dysfunction causing hypoperfusion. In end stage, however, we have 2 modalities for optimization, that is CRRT and peritoneal dialysis at home, so as to prevent hospitalization. This does not improve mortality, it just postpones mortality. Enzymatic optimization. We all know NT-proBNP, ST2, and troponins. Troponins, of course, in ACS. NT-proBNP, we must check in these patients that has the drug treatment be optimized. If the NT-proBNP doesn't decrease at all, it's not a good marker, and of course, there's clinical implications in procedures which you want to do when the NT-proBNP is very high. So enzymatic optimization essentially is NT-proBNP because we can reevaluate. ST2 is one-time test. It is just for prognosis. It is not to be repeated for optimization. Now, the most important, drug optimization. So I'm going to look at clinical parameters. I'm going to look at metabolic parameters. I'm going to look at enzymatic parameters. I'm going to look at renal parameters. Make a checklist and think of all these things when I'm treating a patient of heart failure. Okay. With this, but what is the most important treatment is drug management. So how do I optimize drug therapy today in 2021? Two things, as I said, the concept of congestive heart failure and chronic heart failure. Congestive phase, I'm going to look at congestive phase. So diuretics, maybe sometimes inotropes, all this will require in an acute decompensated heart failure. So congestive phase is optimization is by diuretics. The chronic phase is mortality. So I want to optimize, I want to reduce hospitalizations, I want to reduce mortality. So this is my drug optimization aim when I start using drugs. Now, 2 to 3 or 4 years ago, this was the list of drugs given to patients in general across the board. Of course, plus minus here and there: lenoxin, diuretics, beta blockers, ACE ARBs, L-carnitine, ubiquinone, hydralazine, nitrates. Now, some for symptoms, some as empirical drugs. This was the actual prescription of physicians, cardiologists, if you see, before the advent of two drugs came. Today, the prescription of a congestive heart failure should have basically first only 4. Beta blockers plus minus evaporatin, tachycardia optimization, ARNI, SGLT2 inhibitors, and eplerenone. So 4 pillars, a must. So there is no question. Diuretics, depending upon the congestion and the symptoms, aim, keep my patient warm and dry. And number 2, my creat should not go. Patient should not be hypovolemic, so as you will increase your urea and creatinine. So diuretics optimally, depending upon your clinical judgment and your renal parameters. Okay. So this is the difference between used to write, say, 3-4 years ago and today. These are the important, which it's a must in all patients. There may be a few changes depending upon the hemodynamics and the potassium levels, but that is individual, which we all know, which we can do. But otherwise, this is a must, number 1. Now, ARNI, all new patients. Ideally, ARNI should be given to all new patients. Now, should we shift patients from ACE to AR and ARB who were on ACE and ARBs to ARNI? Number 1, if the response is not significant, 100% you have to shift. Should we shift as a routine? Some people would answer is yes. The ESC guidelines 2021 have said that shifting is 1B indication today. ARNI, ACE is still 1A, but today with the advent of ARNI, in fact, this is a drug which majority of the patients should have, unless there are cost constraints or contraindications. In which patients I would, now, if a patient is on ARNI, which patients I will not use ARNI? Okay, asymptomatic LV systolic dysfunction. That means patient has no symptoms, NYHA class 1, I may think whether I should give it or not. I may just start an ACE. Now, here there is a caveat. There are papers which say that there is nothing called stable congestive heart failure. So essentially, there is nobody who is asymptomatic at all. It is just that you don't ask or the patients don't exert, and that's why they're asymptomatic. So essentially, this particular indication, you have to be careful. Of course, patients on IV inotropes, acute decompensated, and patients with acute LVF in an ACS setting, I would not start ARNI. Now, ARNI and hypotension, you must know this, because if ARNI, the minimum systolic blood pressure where we normally start ARNI in all trials is 95 and above. But if the patient decreases his blood pressure, I would not stop ARNI. I would first think whether I have more diuretics on board, whether there are nitrates which I can reduce. Patient should not be hypovolemic by overdiuresis. If this is not there, then I would reduce the dose of ARNI or sometimes stop ARNI. Interestingly, the new drug, the alpha agonist which has come, Midodrive, this drug now I have been using in almost 10-15 patients. You can give this drug for 2.5 milligrams twice a day, get their blood pressures high, and keep the use of ARNI. And over a period of time, you'll find the hemodynamics improve, and these drugs can be taken out. So Midodrive is the new agent in board where instead of stopping ARNI, I add this drug and give ARNI. So remember this. Will not use, I have shown you this. Now, predictors of LV function. Remember this. See, ARNI perhaps is the only drug which really made a clinical impact on patients' heart failure. Number 1, it remodeled the LV and improved ejection fraction. Similarly, beta blockers showed improvement in LV function. SGLT2, there are a lot of papers now, new trials going on for LV function, except MRAs, epinephrine did not show increase in LV function, but otherwise, and for the predictors of LV function, non-ischemic etiology of LV function, smaller LVs, that means not a very significant, 8 LV of more than 6.5, should be less, higher initial blood pressure. All patients with a BP of 120 and above, in fact, improved the best, and larger initial dose of ARNI. Now, ESC 2021, a few weeks ago, congestive heart failure, ACE still 1A. Why? Because the number of trials and number of patients of ACE are far exceed ARNI or HAL2. No question about it. ARNI, one class, but 1B for switching from ACE or ARBs. In general, telmisartan, olmesartan, all sartans per se, perhaps valsartan is exception, but if I am to use valsartan, I'll use ARNI, should not be the first drug of choice in patients with congestive heart failure. GL2 patients, I would use in all patients. The GFR should be more than 20, some say 15, but 20. Pre-discharge after acute decompensated heart failure, this is the drug to be thought of. And whether you should give ARNI first or HGL2, this is a topic by itself. But let me tell you, I want 4 drugs. So the current concept which has come in the recent papers is what is called new concept in optimization, rapid sequence initiation of quadruple drug therapy. That means beta blockers, ARNI, HGL2, and epinephrine. That means MRAs. Okay, now, what does this mean? We need speed of giving drugs. The whole concept has changed from goal-directed medical therapies to CDMMT, that means comprehensive disease modifying medical therapy. It's just a few months ago. And what is the concept? That yes, it is just don't keep on discussing whether I would give ARNI first or HGL2. Think of the clinical subset of the patient. I want all 4 drugs on board from 1 week to 4 weeks, either in your clinics or if the patient is admitted, from pre-discharge to 4 weeks. This is rapid sequence initiation of 4 drugs. So how do you go? ARNI low dose. Remember, they have clearly given, if you want to start pre-discharge, ARNI 50 milligrams, half twice a day. Start with low dose. HGL2, initiate, no dose changes. Beta blockers, low dose and titrate very slowly. MRA low dose, not 25 milligram, epinephrine 12.5. So they have given the initial doses also. You can sort of, it depends upon the patient's blood pressure. So this is CDMMT, comprehensive modifying medical management of heart failure. Remember this. So I want all these 4 drugs, and then you can use your good clinical discretion to choose which one to start depending upon an acute decompensated state, whether the patient is in that state, whether the patient was on inotropes, he was on IV diuretics, depends upon that, or the patient has come to you with NYHA class 2 to 3, but you are treating in the OPD basis. But this is the concept of optimization of drugs in 2021. Finally, 3 slides. When we optimize, we have done everything. I know from clinical to enzymatic, I have given the best drugs to the patient, and you find failure of clinical response. Think of 3 things. Number 1, look at some echo features which will hamper the effect of these drugs. Look at clinical echo disparity and think of that patient perhaps has reached what is called end-stage heart failure. Now, what are the echo features? So when you look, ask for an echo from a cardiologist, it is just not the ejection fraction. Just don't look at it, 22%, some say it's 25, some it's all eyeballing. So just don't go only by ejection. The echo features which will give you high-risk clinical subsets, EF less than 20, LV dyssynchrony, annular dilatation and mitral regurgitation of the left ventricle, RV dysfunction and pulmonary hypertension, LV diastolic dysfunction, LV thrombus. These are the 7 parameters where my clinical response is going to be suboptimal. Even I may think I've optimized my drugs in the best way. Classic example is RV. Remember, when RV fails, so many patients ask us or come to you, you say his ejection fraction is 20-25 and he's doing everything. He's going around doing his work, as is in NYHA class 1 to 2, well optimized clinically. Why? Until the time the RV dysfunction. So RV dysfunction setting is one of the important parameters of clinical deterioration. Remember this. So despite optimization, when you find that somebody's clinical response is low, think that the RV is going wrong. In fact, there was a ECG criteria many years ago when echoes were not available, that the patient's axis left, when the patients with heart failure came with left bundle branch block, their axis changed from left axis to northwest, right side, right upper quadrant. So whenever this happened, this was the indication that the RV has failed. A very simple ECG finding, but I'm just telling you, there are several papers on that. So these are the parameters where my high-risk clinical subsets may not do well despite a good optimization of drugs. Finally, clinical echo disparity. Echo is not bad. Not these features are not there. Then why the patient is doing well or not well? Remember, optimal circulatory adaptive mechanisms. That means your vasodilatation, your vasoconstrictions, your peripheral circulation, everything, your exercise level of the patient, everything matters when the patient is optimized clinically. Number one. Second, anemia, salt intake, NSAIDs, glitazones, diuretic-induced thiamine deficiency. Give them thiamine. Why? Because chronic dialysis, in fact, thiamine deficiency is one of the contributors to deterioration of LV function. So think about it. And of course, most important is ongoing ischemia, because you can treat ongoing ischemia. So whenever you find, again, clinical echo, not the echo parameters which I have shown, but when the echo is reasonably okay, echo is 30-35, patient's response is not good. So clinically, he is not optimized. Think of the following. So when I look at optimization, I look at the parameters, I look at proper drug optimization with the current concept of 4 pillars coming in within 4 weeks. If this doesn't work, these are the 2 things I will see. And if nothing works, then think that the patient has gone into what is called end-stage heart failure. What is end-stage heart failure? Essentially, the patient becomes what is called vasoplegic. Vasoplegic means the patient doesn't respond to drugs. In fact, this is the time the patient is going to be vasoplegic. He's going to have renal deterioration, which is very bad. He's going to have significant RV dysfunction and moderate to severe pulmonary hypertension. And then this is the time you have to go for advanced management. Otherwise, then here, this is the time, don't go on playing with drugs. In fact, so here in advanced management, we know for rhythm, you have ICDs, you have CRDs for LV function, you have LVADs, and you have cardiac transplant. So we have to think that which subset the patient may fit if it is possible to do it. But this is the stage when my optimization of clinical response fails, and I would look at this. Interestingly, you must know that end-stage heart failure, when the patient is on a transplant list, remember, in fact, we omit ARBs and even ARNI because the patient becomes vasoplegic. In fact, it is well known, remember, even for non-cardiac surgeries in patients with heart failure in general, remember, if the patients are on RG, ARNI or SGLT2 inhibitors, please stop both these drugs 7 days prior to non-cardiac surgery. This is a practical tip which I am giving you. But coming back to end stage, patient is vasoplegic. Do not keep these patients on ARNI just before transplant. And remember, again, I am mentioning, even your transplant reference should preferably be before RV dysfunction and pH sets in. The moment pH becomes moderate to severe, you know you require a heart-lung transplant. The whole subset changes. So here today, in practice, we have to look, even when the patient is not responding, I would like to know that I should at least refer the patient to a advanced management at the right time. It's too late if you send a patient with RV dysfunction. You cannot have LVAD devices with severe RV dysfunction, but you have to have a transplant, but there should be no pulmonary hypertension or severe RV systolic dysfunction. Now, finally, in conclusion, so when I talk of optimization of medical therapy today, friends, you must know, and this is a concept that I must know what my aim is. My aim is symptoms, hospitalization, and mortality. So this is my optimization is my aim. When I want to look at optimization of various subsets. I want to look at my clinical medicine. I want to look at enzymes. I want to look at the echo. I want to look at all the parameters, the renal dysfunction, and optimize the clinical subset. So I must know what has deteriorated in the patient. Number one, drugs. Sequence, speed, and dose. Remember this. This is important. Sequence, speed, and dose. Just don't keep on arguing ARNI first or SGLT. There are webinars after webinars. discussing this. No, you should look at the clinical hemodynamics of the patient and look at the sequence, speed, and dose. Reasons of failure to respond. I told you 3 reasons of failure to respond. Despite optimization, that means I have optimized everything, patient has not responded. What are the reasons? And finally, please, if at all the clinical optimization, drug optimization fails, please refer the patients for advanced management at the right time. Thank you very much for a patient hearing.
Thank you so much, Dr. Sathe, for that superb and practical and comprehensive approach to optimization of medical therapy in heart failure. There was a lot to learn from your lecture, and we also thank you very much for being a part of IDEC. Thank you, sir. I don't see any questions in the chat box. Thank you very much.
Tired listening to lectures.
Okay, thank you, sir. Thank you.